Dr. Sonal Agarwal, welcome. She's an practicing pediatrician and allergist from Bangalore.
So Dr. Sonal right now from Whitefield, she has done Diplomat of, so two are from UK and she's special from Diplomat of American Board of Pediatrics, DA and C Vellore. Right now she's the consultant there in Children's Clinic and Allergy and Asthma Center. And she has the former consultant at Columbia Hospital. And she was the consultant pediatrician at San Diego, USA, as well as staff physician at once again San Diego, and consultant pediatrician case permanent. That's also in California as well as San Jose. She has the present case lecture, given case lecture as well as faculty in DA program and speaker in many national and international forum, contributed to the growth and development and pediatric vaccination. She has got interest as well as growth and development.
Hello. So, Dr. Gnanamurthy, and thank you, Dr. Somashekar. Dr. Gnanamurthy kind of did mention a little bit, and I'm going to kind of talk a little bit more about that. So, as doctors, we are usually very observant, and that's a major part of our diagnosing skills. So as soon as the patient walks in, there are a few things that you can see in kids with allergic rhinitis. It might not be all of them, but you will see a few of them. One is allergic shyness. This is the discoloration or the darkening of the lower eyelids because of nasal congestion and venous congestion. Then there is the Denny-Morgan lines. These are accentuated folds in the lower eyelids again because of repeated rubbing of the eyes. The other is allergic salute, which is a very characteristic thing that a lot of kids will do, which is they have itching in the nose and they are going to kind of rub the nose up like this. And because of that, over time, they will develop a transverse crease. The image on the C where the arrow is, you can see the transverse crease, which is there for most patients. Now, the symptoms could be like cold that don't go away for weeks or months, and you see that very often. Early morning sneezes, and especially these kids are sensitive to altering temperature like AC or strong smells like perfumes, incense sticks, or even if there's frying in the house. They will have itchy nose, eyes, or throat. But what I usually see is the itchy nose and eyes and throat comes for a little bit older kids. The younger kids, a lot of times, come more with congestion. And then because of the congestion, there's mouth breathing that you will see. And snoring, again, a very important one that patients, when you have to ask them sometimes to get this. And then, of course, there are other things that come because of the mouth breathing and snoring. Yeah, I think this is it. And yes, the next slide, please. Thanks. And when you examine them now, you will see that the nasal turbinates are pale and boggy. So they are very different than what you see in a URI, which is usually red and inflamed. The secretions here are also thin and watery as compared to URI, which are usually mucoid. There is cobblestoning of the posterior pharynx due to chronic postnasal drip. And also make sure that for these kids, look for other allergic attributes like conditions like atopic dermatitis or asthma. Ask for it and look for it. And also pay attention to the secondary impact that it has on sleep, and then dysfunctional eustachian tube, which can lead to chronic ear effusion, which can then decrease the hearing and affect speech development in younger kids. So history taking, this has always been very important. I think so. We talk to our UG and PG students, and then over time, sometimes we forget how important history taking is. So the first history, or when we meet the patient, what do we ask about? So we ask about mainly the classical triad that we had talked about nasal congestion, rhinorrhea, and sneezing. And then we ask about when do they get these symptoms? Do they get it all the time? or that's perennial, or seasonal. That was also mentioned. That's how we categorize with the area classification. And let's also pay attention to the comorbidities that we talked about atopic dermatitis and asthma. So the first history that we take, the aim here is not to make a diagnosis. We need to be trying to figure out whether this child or this patient has an allergic phenotype, whether it kind of they fit in a patient who is most likely going to have an allergy. And then we progress to testing. And let's not straight away test patient as soon as they walk in with symptoms of complaining or self-diagnosing themselves as having allergies, because a lot of times those are just perceptions and those are not true allergic symptoms. Next slide, please. And then after we've done the first history, then as Dr. Nanda mentioned, we do testing. So again, the skin prick test is the gold standard and is much more specific, easier to done, can cover your local aero allergens much better. And after that, just the getting the skin test or the IgE test positive is just a sensitization, as was mentioned earlier too. That doesn't mean that the patient has allergy. So there should be a follow-up interview, a follow-up talking about, the questions will be based more on the correlation of those symptoms with those allergens. And that's how we separate whether the patient really has allergic rhinitis or it's a non-allergic rhinitis, which is a completely different topic to talk about. And then whether these allergens, they're not real allergens and they're just irritants, and so the patient doesn't really need an allergy treatment. So as again, the same thing I'm going to emphasize again, that the positive test is merely a sensitization. But when we take the second history, when we correlate our test, that's when it converts into a clinical diagnosis of allergic rhinitis. So monitoring long-term, we all know allergic rhinitis, asthma, these are all chronic diseases, long-term diseases. So once we have put the patient on medication, we definitely need to follow them up. And I've just put a quick picture here of the allergic march, because that is what we are trying to halt through several ways. And as you see, when the kids are younger, you'll see more of the food allergies and atopic dermatitis. And then as they get older, we are getting allergic rhinitis and allergic asthma. Next slide, please. So long-term care, before I kind of start talking more about it, I'm again going to emphasize that all that we can do all kind of long care, but that's just kind of touching the surface of the tip of the iceberg. Allergen immunotherapy is the only treatment that can provide long-term remission, because it is a disease-modifying treatment, and we in medicine have very few of those treatments. So now once we've put on the medication, let's not forget about the preventive measures that was mentioned in the previous couple of speakers spoke about it. Let's keep that going. So the nose has to deal with less problems to begin with. Nasals and sinus washes also decrease the allergen load, and I have really found them to work magically in a lot of my patients for long-term treatment. And very importantly, the next point that I'm going to talk about, as soon as you talk about steroids, most of can we go back just once, the previous slide? Thank you. As soon as we talk about steroids, the patients just kind of, they don't want to do steroids and they're very scared about it. So let's reassure the patients that there have been lots of studies that have shown that the long-term use of intranasal corticosteroids does not alter the growth, the ultimate growth of the child, and does not alter the growth velocity for a long time. And of course, ensuring proper technique, as Dr. Gnanamurthy has also talked about, is very important. Otherwise, we feel like the medicine is not working. Next slide, please. Now, once the patient is doing well, so what do you do next? If they have been doing really well for 3 months, then we can try and de-escalate the intranasal corticosteroids. So either you can decrease it by 50%, or for the people who have more of pollen allergies, make sure that you can start the intranasal corticosteroid only 2 weeks prior to the pollen season and then continue through the season rather than giving it all year round. And another one, we all have heard of asthma action plan, but there's also an allergy action plan, because there will be days where they will have breakthrough allergies. So let the patient know that they can take some second generation antihistamines on the breakthrough days, and they can start the intranasal corticosteroid if this repeated breakthrough keeps on happening, because there's something that has irritated the turbinates, and let's kind of soothe them down and go back to where we were before. So yeah, so that's about it for the long term.
Thank you.